study that's going on that looks at people with super high LDLs on a keto diet. They also have super high HDLs. And I think that's an important point the old way we taught this was there was good cholesterol, the HDL, and if that's really high, it's protective. Now, because there are no drugs to treat HDL, it hasn't made its way into the drug treatment guidelines, but I can raise someone's HDL by changing the food and by having them eat more saturated fat, which is kind of strange because people have been told not to have saturated fat. Well, maybe that's why their HDLs are so low.
Wellness isn't black and white, so why should your choices be? On High Energy Life, we dig into nutrition, health, and science with an open mind, inspiring you to make choices that actually work for you. Our mantra? Embrace nuance, ask questions, and always reserve the right to change your mind. Now enjoy today's episode. I'm your host, Carly.
And I'm your host, Alex. Thank you so much for sharing your time with us to tell a little bit about your knowledge and your wisdom. So just to get started, could you provide a brief background about yourself, your educational experience, your clinical experience, and why someone might want to take advice from you?
Yeah, so my name is Eric Westman. I'm an internist at Duke University, internal medicine specialist. And I started doing research on low carb or keto diets 25 years ago. Well, 20, every year it goes up, 26. So two of my patients, I was practicing at a VA hospital. Two of my patients lost over 50 pounds each doing a low carb diet, and I was curious about it. And so we started to study and publish papers about low carb, keto / carnivore, now are variations on the theme. But alongside of that research, and now 20 years after the research, I've been using low carb diets in a clinical setting with people with type 2 diabetes, high blood pressure, obesity, lots of different medical conditions. And so I'm really able to use the metabolic changes that occur with this kind of diet change to treat and reverse lots of chronic conditions that my internal medicine colleagues use medications for. Kind of stepping back, I can use the diet to replace or eliminate medications, which is kind of cool.
So in your clinical experience now, so in your practice, do you primarily use just metabolic suggestions and use metabolic health as your primary mode of healing? Or do you combine both the metabolic side with more of the conventional prescription-based side that our conventional medical system is founded on?
Yeah, well, so people come to me on medications generally, right? And if I can talk to someone and ask what they want to do, most people will be willing to try a diet change. And the diet that I use is predominantly the keto diet. The medications are helpful for at the beginning. I tend not to want to prescribe them. Well, so the reason I'm kind of giving you a range is that some people have watched my YouTube channel and know exactly what they want, and they come in, they want to do keto, or they've already done it. There are some people who have no idea what I do. Their doctor refers them to me. Some people are even coming in on the new GLP-1 medications for obesity treatment, that sort of thing. But if I can step back and say, we have diets, we have pills, we have medications, like shots, and before there were shots, there were pills, and before there were pills, there were diets that work. I can generally walk people back to trying some kind of lifestyle change and diet. Yeah, so not everyone will want to do a keto diet, and I'm able to prescribe medications as a physician, but that's kind of what we're known for. And so depending on how someone gets to the office, if they already know, they've been watching my videos, that sort of thing, it's an easy sell, so to speak. People are already motivated to do it.
Yeah, I appreciate that approach, though, and especially on social media, I find that there's the conventional medicine doctors that appear to shun nutrition and lifestyle based interventions, and many of
Really? Yeah.
the nutritionists and even doctors that primarily or first go to the lifestyle and nutrition interventions come across as we should never look to conventional medicine. And I disagree with that. And I really appreciate your approach of, you know what, we should, yeah, let's look to what are you willing to, what can we go, what can we change with your diet and lifestyle as the first form of prevention or healing. But sometimes medications and such are applicable, and it can be very patient context driven. So I appreciate that approach.
I was going to say you can kind of tell if the influencer or someone you're learning from is in a clinic that, you know, dealing with real people. They'll tend to be humble and have different approaches. If they're just an influencer pushing out information, you know, it doesn't even have to work, right? So knowing that someone has had a clinic or is currently in a clinic is important for me as I teach people to consume the information on the internet.
Absolutely. So in your clinical experience with now 26 years, you've been doing something that would be considered unconventional for a very long time. And so I'm curious, with your career of working with other practitioners, how has your relationship evolved? Either is it contentious or is it very cordial with practitioners that may not be as far along as you are on the nutrition side of things in their practice?
Yeah, that's a great question. And so I'm working at a university. There are hundreds of doctors, actually hundreds of internists even. So even in my group, you know, the pandemic kind of led us to separate. And it's actually been, it hasn't happened yet that we all kind of co-locate for our grand rounds anymore. It's interesting, we're doing that on Zoom. But even when we were going to the same meeting and all, you know, a lot of other internists don't agree with what I do at the university level. Many of them refer me their patients, so they do agree with what I do. As far as kind of when someone asks they want to do this in their own area, I just remind them that it's important to maintain the collegial relationships and to actually like brief some of your colleagues on what you're doing, and you know, share the patient stories. Share. So in my clinic, I'm co-located with maybe a dozen other doctors, and I will share. Oh, look at this patient. You know, they like with, you know, all excited and you got them off insulin and all this, and you know, I want to make sure that at least a few doctors in my division, is called the department and division, understand really well what I do, because then they can go to bat for me if ever needed. But honestly, because we started with clinical trials, publishing the clinical trials in good major journals, I've never had any local pushback for what I do, because my university is very supportive of data-driven kind of practice even. So others may not agree with me, but no one's kicked me out, right? I've been at Duke now since 1990. And while other universities have other things on their plate and all, and I'm only aware of 2 or 3 other universities that have a practice like mine, but there are keto low carb practices within university settings outside of Duke, which is also kind of a demonstration that this is not some, quackery sort of thing. Publish the papers, and then I do the politicking of showing my patient results to my colleagues and friends as a way to make sure they understand what I'm doing. I'm not harming anybody. That is one way to say it. In fact, I'm helping.
Yeah, it's good to hear at least a few universities are exploring the metabolic health route and specifically the ketogenic and even carnivore route for health. So on a broader context, though, because it's only a few universities to my understanding, and even just very recently, I try not to get political in any of the work that I do as a nutritionist and the content that I try and put out. But it is interwoven, especially with the current administration. There is a focus on nutrition. Of course, there's lots of disagreements about what is nutritious and what is healthy. But very recently, there was a press conference about moving towards requiring nutrition education in medical schools, which a lot of people are shocked that I don't believe it is an official requirement right now, and very few schools have official courses on nutrition in medical training. And so I'm curious, what are your thoughts on mandating at least a few nutrition courses throughout medical school training?
Well, it's kind of sad that there has to be a mandate about it, right? So can you imagine that a doctor is really taught nothing about nutrition? I mean, that's the sad state of affairs. I mean, the medical students get very little nutrition training. The only time I really learned about nutrition, in the 80s, was in the context of total parenteral nutrition. Like, what do you feed someone in the vein when they can't eat at all? So I learned hospital-based nutrition. And in the 80s, looking back, something happened where the nutrition education was kind of taken out of medical curricula, and it's kind of unbelievable, really, because can you imagine putting bad gas into your car, dirty gas with sand in it or something? It's the idea that it doesn't matter to human health. That's kind of the implication. If doctors aren't taught about nutrition, the implication is that it doesn't matter, and that's just the contrary. Au contraire, when I can change the nutrition, then we can argue about what's the optimal one, but how can we can agree on, cut out the ultra processed food and just having sugar all day long. We'll probably all agree that's a good thing to do to minimize. We can argue whether it should be plant-based or animal-based or both. I don't really care, but having nutrition being something that doctors learn, I think, is extremely important. And I'm happy that it seems like there's kind of a mandate, though, with have you looked at all of the detail that they have kind of covered? I think it's what's the word? Some of it's not evidence-based. So if the requirement is to have nutrition in the medical school and a lot of it's not evidence-based, I don't know that that's a good thing, right? So how it plays out.
And I have
important.
not personally dug into those details yet. And that would be one of my concerns, is depending on what they're actually teaching in the nutrition courses, it may be helpful, but maybe actually counter
Make it work.
to what we're trying to do. So along those
Well,
lines,
but
what do
would
you
you agree
go ahead?
that would you agree that it might be a good sign or a nod if the dean gets up or the professor says, what people eat is important to consider when you're a doctor. Wouldn't that be a good thing?
Absolutely. Even just talking and shifting the conversation in a medical setting to nutrition itself, you're absolutely correct that regardless of the content of what we're actually talking about, just the fact that nutrition is mentioned in a clinical setting or clinical education setting is a massive step forward, which tells you where we're at, and that it's a little sad that that is a step forward, but it is indeed a step forward. So baby steps.
Yeah. Well, what do you think of the new dietary guideline? Because that came out with a emphasis on real food. That seems like a
Yeah,
reasonable.
absolutely. I am a overall huge fan. Of course, with anything, I can nitpick it and find things that I disagree with in the guidelines, and even the pyramid, flipping the pyramid itself, and then the associated literature along with it. There's a little bit of conflicting information, in my opinion, but in the grand scheme of things, as a nutrition coach, if any of my clients start to eat the way that of the new nutritional guidelines outline, I would call that a massive success. So
Yeah.
overall,
Yeah, me
I'm
too.
very happy with it. Now, along with the political aspect of it, I have actually even have extended family who they have not been privy to my 10 years of researching nutrition, and they only recently found out that I am doing this nutrition coaching thing now, and they think they view me as basically just hopping alongside a very ultra conservative political party that I'm just along with the bandwagon, and don't realize that no, this new information and the new nutrition guidelines actually drive quite well with the past 10 years of what I've been researching. And I would have just as well said I disagree with the information that came out if I did. But no, it actually drives quite well with what I already have been researching and believe myself. So I'm guessing that you're somewhat along the same lines of agreeing with the new guidelines.
Yeah, and the way it came out, having a 10-page or 9 or 10-page summary, kind of high level overview, was good. I think there are supplements or appendices, I think they call them, that have the 400-page evidence papers behind them, and I've talked to Don Lehman, who was one of the authors of one, and Ty Beal, who authored the vegetarian part of it. And actually, this is the most evidence-based dietary guideline that there's ever been, because it used to be kind of a nutritional epidemiology, how to avoid micronutrient deficiencies, kind of a clunky sort of document. And now I think it's readable and hopefully will have benefits. And if someone thinks it's bad, they should study it and show that it's bad. Had that happened with the first pyramid came out, we wouldn't have had the next 20 years of kind of disastrous consequence. So if actually this pyramid, the inverted pyramid, has been studied in clinical research, and so the ones before really had not been studied in clinical research, which is, I know, kind of weird to hear, but that's the way the political process had worked.
Absolutely. And I think when you dig into the history of how those guidelines came to be and the political and the industry influence that came along with producing those guidelines, and even still exist, especially in the medical system. It at least adds context and framing to the discussion. So along with the increased focus and shift towards nutrition, at least somewhat in medical education, a couple questions on: are there any significant misconceptions that you think your fellow physicians still hold? And are there any teachings related to nutrition in the medical system that you think is actively harmful to at least a majority of patients?
Good questions. I don't know that. Well, let me think for a minute. I think most physicians, because they're not really trained in school or even after school, except through drug training, they get a pharmaceutical approach. Most physicians in internal medicine, family medicine, use medication and they use drugs. And there's a failure, I think, to believe that their patients will make lifestyle change. And that is really sad. So I find that doctors many times don't even give the patient a fair shake or a chance to change lifestyle. They don't know how to teach it. They don't know, well, other than to say that do the Mediterranean diet. That's kind of like the joke we have in the nutrition world, is that doctors all know that's the best, although there's not really a lot of evidence for it. But they say that, but then they don't know how to teach it. So it's not very helpful for their patients. So I think that's maybe the number one misconception, that the Mediterranean diet is the best. It's like a buzzword. And then the failure to think that their patient will make a change. But part of it, I think, is the lack of accountability and support. If doctors sometimes refer to other support people, but I think it's great to have more nutrition coaches. And I'm part of an organization called the Society of Metabolic Health Practitioners, that their whole mission is to train not only physicians but non-physicians on how to help people make lifestyle change, including low-carb and keto diets. I think the other main misconception among patients and doctors alike is that exercise will fix everything. And it's just not true. In fact, people will come to me having tried more exercise, and and I can't lose weight. Something's wrong. I'm exercising more and more, and I explain to them, no, it doesn't work. Exercise without regard to the diet really doesn't work for losing weight. And then, of course, people think back to their younger days when it did, and I have to just gently explain that, time has passed and you're a little older, perhaps, and it doesn't work now. But anyway, so those are kind of the misconceptions, is that we know that there's one best diet and that exercise will fix everything, and those aren't really true.
Yeah, there's a lot of nuance in everything. It's interesting you bring up in the medical system, in doctor-patient interactions, and many doctors assume that patients won't change anything about their lifestyle. I've had a lot of conversations on Twitter, now X, and I don't like social media myself, but I primarily use it to have conversations with doctors and researchers and the like. And a handful of times I will specifically tag and call out and ask questions to the doctors that appear to be very much pharmaceutical aligned, I'll call it. and ask them very specific questions about why don't we, in a clinical setting, focus more on lifestyle interventions, at least at minimum alongside pharmaceutical options. And for the most part, I just get platitudes as a response until we have a few back and forths, and I have to hone in specifically on that question. And every time I do, the response finally becomes, we just don't have the resources, the nutritionists, the dietitians, those resources in my practice to pursue that. So the fallback then becomes, we're just going to prescribe a medication. So
Quicker.
the default is we just have to prescribe medications because we don't have the resources. And so ultimately it's, yes, that would likely work for many people if we could dedicate time to helping a patient implement a change in their life, but I just don't have the people to do so. So it becomes very interesting, and it's just the platitudes that, I mean, part of it is the social media aspect of just shouting at strangers until you take the time to have an in-depth conversation with them, and eventually they have nothing to fall back on but to admit, yes, nutrition and lifestyle can make a massive difference. We just don't do it, ultimately.
Well, I think what's hidden in that response is they don't know what to do, right? So if they were taught that you could ask what people are eating and drinking, or if they were taught to give people a piece of paper that says, list out what you're eating and drinking in a typical day, that's what I do. It takes me a millisecond to see what people are eating and drinking. And if they were taught, so that's assessing the diet, doesn't really have to take much time. If you give people something to write on before you get in the room, or a iPad, or whatever system you're using. But then the knowledge to know that if someone has diabetes and they're drinking sugar, that this is not a good thing and that it's going to raise the blood sugar. You could simply say, you have to not drink sugar, especially if someone has diabetes or pre-diabetes. So that's a pretty focused sort of thing to say. But I think then it gets complicated because in the past, doctors were told that heart disease was caused by fat in the food. And so a lot of doctors would say, well, and don't have fat and don't have saturated fat. Well, that's not a very practical way to give guidance because people don't know what saturated fat is and what foods have it. And so that gets into just don't have red meat, which is not really evidence-based thing to say. So without the proper baseline knowledge, it's probably better the doctor doesn't talk about nutrition, except for the sugar thing. If even my patients, when they learn that there's only a teaspoon of sugar in the entire bloodstream, I'll write it out, calculate it for them. They realize I'm not going to ever want anything that has more than a teaspoon of sugar. It's going to raise my blood sugar. And most doctors I talk to they've never made that calculation. So if we could just have a minimal level of teaching for doctors about sugar and that starches get digested to sugar. So what I see happening is actually the very practical, people are being given a continuous glucose monitor and are told to just eat to lower your blood glucose. And then you don't even need the doctor to say anything. So if the practical reality is that it's complicated, nutrition is, and if they're not trained as students and residents, and we learn from companies giving us information, where would we get vitamin C if we didn't drink orange juice, right? The Florida orange growers have indoctrinated in our heads that the only place you can get vitamin C is in oranges, right? So, and that's not true. But so I don't know. Most doctors just don't have the tool to say the right. They don't have the education to say something, and in general, like if I don't know a drug, I'm not a big drug prescriber. If I don't know it, I don't say much about it because I don't know it. So I think most doctors just don't know about nutrition, so they don't say it, and they're kind of hiding behind. I just don't know what to, not enough time. No, they just don't know. How is that for a? They won't admit it.
That's that's where education matters. And I put on lots of in-person seminars, and one point that I try to get across is that, I mean, doctors are extremely hardworking, extremely intelligent, extremely bright, and they want to do the best for you, but they're just not taught nutrition. That's not part of the education that they're given. And so there is a place for doctors, and there also is a place for nutritionists. But along those lines, even just the understanding of nutrients and how they impact your body. One of the debates I see pop up all the time, even between, especially on social media, even from doctors that have hundreds of thousands of followers, is the idea of it's just calories in versus calories out. So you published a study a few years ago. I believe that your study involved people eating almost 6,000 calories a day. So we'd call that an overfeeding study. But those 6,000 calories, there's a different composition of those calories between each of the groups. And your results, I believe, were the weight gain, because all of them gained weight eating so many calories. They all gained weight, but they gained drastically different amounts of weight. So to me, that suggests, and even other reasons why, but it's not just calories in, calories out. But I'm curious, the setting that you conducted your study was in a pretty significant overfeeding setting.
Yeah.
Do you think
Well,
you
so
may
I
have
think
seen different?
I think it's it's generous to even call it a study. It was one man's own N of one trial. So, and we published that paper, but so that the same individual overfed, overconsumed, you have three different diets, and he gained weight on all three, which he did gain weight on a low carb keto diet, but he didn't gain much. And I think the range was like from 3 pounds to 11 pounds over the same period of time. So it's kind of like we call it a straw man out there, where you have a case where clearly the calories were handled differently. Yeah, so the type of calorie and the hormonal response to the calorie you eat makes a big difference. And actually, I'd love to see this one man's N of one trial repeated. And if someone thinks that it isn't true, then you should do a study and show that his experience isn't right, because there's an older paper some years ago where there was it was called an overfeeding trial, but it's kind of what people are eating today now normally. The typical American overfeeds. But this Sam Feltham was the man who did his own N of one trial. I contacted him and got the information to help him write the paper. But I would say that it's not definitive by any means, and that it's an open argument now that the people who say a calorie is a calorie have to come out and kind of refute this as the straw man sort of thing. But we've known for a long time that the sugar is handled differently. And starches raise the blood sugar, and then insulin goes up, and insulin is the fattening hormone, so that carbs tend to be the fattening element in the food. Fat doesn't raise the insulin level at all because it doesn't raise the blood sugar. Protein raises insulin a little bit, but not as much as carbs, which has some of the kind of keto, low carb intellectuals, if you will, the people who have taught this for a long time, thinking that insulin really isn't a hormone that's supposed to be handling glucose. It's really, its role is to handle amino acids or protein. And so the idea that it's being used for something else, or only in a time of plenty, would insulin come out and help sugar get in the cells and help the fat get stored. So the hormonal response to food has been known for a long time that it's different. I think the calories in, calories out versus, it's called the carbohydrate insulin hypothesis mechanism, both have an element of truth to them. For example, you might say, if I take you to 0 calories, you will lose weight. And that's true. I mean, all you have to do is watch one of these reality shows, Naked and Afraid or Alone, where people are out in the middle of nowhere not eating anything. They all lose a pound or 2 per day. And it's because they're not eating anything. Of course, the insulin hormone has gone down as well. So there's that carbohydrate insulin hypothesis. So the calories actually are important. It's just how they're used in the body depends on what type of calorie you eat.
Mm-hmm. You mentioned Naked and Afraid and how everybody on that show loses weight. I've heard a handful of interviews from participants afterwards on that that were on that show, and just to emphasize the importance of hormones, it does appear that on average the men on that show, they'll lose a pound a week very consistently through the whole show, whereas oftentimes the women on the show, they start by losing weight, but that plateaus, and usually the women struggle much more, or not necessarily struggle to lose weight, but the weight doesn't come off nearly as much, and especially as the show goes on. And so that even we all know that the hormone balance is relatively simple for men compared to women. And so the interplay of not just insulin, but all of the other hormones involved are also really important.
Yeah, and I think that plays out in a weight loss clinic too. The men will lose weight faster, typically, not in everyone, but most of the time, yeah. And if you have menstrual cycles, then the water weight can be a distraction. The water weight can go up in regard to the menstrual cycle, but the main point of Naked and Afraid to me, and when I'm teaching somebody, is that if you don't eat, you'll lose weight. I mean, and there's an internet meme out there where people will come in and say, well, I know I'm not eating enough, so I'm not losing weight. And I just look at them like, does that make sense? That you're not eating enough, so you're not. So this idea that there's a starvation mode where you don't lose anything, where if you're not eating enough, it's not true. I mean, you want to eat less to lose weight, right? So anyway, a lot of people will come in thinking exercise fixes everything, and that I'm not eating enough, so I'm not losing weight, which makes no sense to me.
Do you think there is any truth to the idea that, let's say you are drastically restricting calories for many years to decades, that you do naturally slow down your basal metabolic rate, and then it may become harder to stay in a caloric deficit because you're already so low?
Yeah, I do. Yeah, so that was also demonstrated in the study of the Biggest Loser contestants, where they lost weight fast under drastic circumstances. And I saw a dietitian talk about the Biggest Loser show, and she was shocked because she wasn't given any control for the contestants. And what would you eat if you were trying to lose weight by diet and exercise, and you know, you win $1 million, what would you eat? Nothing. So basically, she told the story, and we were all kind of shocked that people don't eat on that show because they're trying to win the $1 million, and she couldn't tell people to eat. So anyway, yeah, if you do weight loss surgery, or even I'll bet even with some of the newer GLP-1 shots, people are losing so fast that it will lead to a reduced basal metabolic rate over time. Um, I'm not able to measure the basal metabolic rate directly in my clinic, but we have that capability at Duke. So I'll send people over to a machine where they breathe in and out in a globe, and they can measure the metabolic rate directly. But yeah, if you've gone through rapid weight loss or weight loss surgery, or the Biggest Loser show, I guess, your metabolic rate can be so low that you can't eat much, and if you want to lose weight, and people come in complaining. Now, because I'm not eating anything, well, you're not going to be able to eat much if your metabolic rate is that low. But the medical side, so as a physician, I can prescribe things, and there are medicines that we can use to raise the metabolic rate. Of course, they're not typically things we talk about to do that, but one of the weight loss pills we use a lot is called phentermine, and the phentermine pill is an appetite suppressant, but it also raises the metabolic rate a little bit. It gives you a little energy, or some people call it jitteriness, and they don't like it. But the other medicine that can raise the metabolic rate is thyroid hormone. And so if you're stuck like that, and you're not losing weight, and you haven't had a thyroid hormone measurement, and even then there is kind of a nuance to getting the right thyroid measurements done. We can use thyroid medication to raise the metabolic rate for people, but it's not much that we can do that, because you get into the tachycardia, fast heartbeats and palpitations, things like that. So a medical weight loss program, we train doctors to think in these terms, so that we would say don't go under 800 calories a day or 1,000 without medical supervision, which means if someone comes to an obesity medicine specialist like me, we do a thorough history and physical, ask about surgery, weight loss surgery in the past, and then we do a certain baseline labs, blood tests, to make sure that there's no metabolic problem, especially thyroid. So if someone's stuck, yeah, you got to think about the metabolic rate, and there might be a therapeutic tool that we could use for that, or you teach people to just eat much less, and that's hard for a lot of people.
Mm-hmm. I have been surprised at the number of clients that have come to me that are on thyroid medications. I think that one, and I coach, many of my clients are middle to older age women, and many of them, again, thyroid medication seems to be a very common prescription. The other one that I don't even remember the name you mentioned first, I have actually never heard of that one. But talking about phentermine, talking about medications, talking about medications like GLP-1 drugs, Ozempic, Wegovy, that type of thing. So, of course, those are dominating the obesity conversation. You see commercials all the time. We just had the Winter Olympics, and every other commercial was something along those lines. So if a patient came to you and said, I want to try out keto, help me do that, but I also want to take Ozempic, is that a synergistic solution, or do you think it is a mistake to do both at the same time, at least initially?
Yeah, I have, great question. I don't have a lot of clinical experience with combining the two effective programs by themselves. So keto is effective without pills and shots. The GLP-1s are effective without even telling someone what to eat or not to eat. So maybe, I don't know, 6 to 10 people I have tried the combination, and for some people it's too strong. The nausea from the GLP-1 might be enhanced. The main side effect for the weight loss shots is nausea, and then we prescribe a pill for nausea for people to get through that. And I prescribe a pill for the side effect of a pill that a diet would work in anyways. But if someone is fixed on using a shot, I will just explain that before the shots there were pills, and I think it's pretty common that most people haven't heard of these weight loss pills. It's okay. The obesity medicine practice, I'm past president of this organization of 5,000 doctors. All we had were the pills for a while. And then before the pills, there were diets. And so I can typically talk someone into not spending $500 a month on the shot. If their insurance doesn't cover it, they're at risk for $350 to $500 a month. And I explain that the diet costs nothing. I mean, you have to buy food anyway. And then I explain that the pills and the shots have side effects like the dry mouth and insomnia for phentermine and the GI problems for the shots. And with a diet, you don't really have any side effects, maybe a day or two of headache. And so given in that context, I mean, and I won't play up if someone really wants to try the medications, I will certainly prescribe it. In a clinical practice, I don't want to make anyone mad at me that I do have supervisors, and we want to satisfy what people in general want, as long as it's a safe recommendation. But I like to educate people. Right now, most other doctors really just reach for the shot, and they don't fully educate people that there are other options. It's fascinating. The field of medicine, I think, is going to change because of these shot medications. It not only helps with weight loss, it reverses type 2 diabetes. There are studies now showing reversal of heart attacks and heart failure events. Of course, the diet itself would do that as well, but it's the first ones to the gate, out of the gate, so to speak, are the companies that are using the shots. So anyway, my field of obesity medicine has now pretty much gotten into the prescribing of all these. They're going to be third and fourth generation shots. They're going to be ones that last a month. They're going to be medicines added to counteract the side effects of it. So anyway, it's just the beginning.
Yeah, making note of
And diet still works.
side effects.
Diet.
Diet absolutely works alongside the exercise and weight training and such. The combination, and yeah, it's really heartening and important to admit even some of the unintended positive side effects of these weight loss drugs. Now, how much of that is just the fact that an individual is losing weight and becoming a healthy weight, and how much are there other unintended side effects that do benefit, let's say, inflammation? So how do we extrapolate those out? But just acknowledging that, yes, there are other beneficial effects from these drugs. Now, of course, there are negative side effects too, and we can sidestep those side effects if we focus specifically first on nutrition and only bring in the drugs when necessary. But having that acknowledgement is really important for a productive conversation.
Yeah.
So
the saying out there is, if you had a dirty fishbowl, you wouldn't just medicate the fish to drink less of the dirty water. You would change the fish bowl water, right? So if people are just eating less of the garbage that they were eating before, you can lose weight, but the machinery, the metabolic machinery isn't going to be optimized. Of course, the human body is pretty resilient, and but we worry about muscle mass loss from the rapid weight loss with the use of medications and even weight loss surgery. So, advantage diet and exercise is that it's cheaper, fewer side effects, and you don't lose muscle mass or as much. I think everyone should start trying weight loss or reversal of diabetes with diet and exercise alone first. But I know some people don't want to wait or feel fixated that there's something magic about the medication. Just get you to eat less.
That's actually a perfect segue. The eating less of dirty water, dirty ingredients, bringing me to the American food supply and the food industry and all of the junk that's in our food system. So the two of us met at the Citizen Science Foundation COSI conference, metabolic health conference that is largely a ketogenic conference. And one of the things that struck me was the talks that were specifically about food and nutrition were very hyper-focused on macronutrients. So your carbs, your protein, and your fats, and what are their correct ratios. There was very little talk about micronutrients. And maybe part of it was that as a whole, the participants, I think, were very focused already on getting their macronutrients from whole foods and real foods that will be accompanied by micronutrients. But there really wasn't much discussion. And I find that actually even in the general discussion on social media and wherever, that micronutrients are not focused on very much. So coming back to the American dirty food supply, what your thoughts are on, let's say, starting tomorrow, if the food industry decided to completely reformulate the food supply and all of Kraft and Mandelas and General Foods and what all of our food companies that supply most of what's on the grocery store shelves, if they completely went ketogenic, all of the food on the shelves was completely ketogenic, do you think that alone would largely solve the metabolic crisis that we have? Or would that still be missing something very substantial, even if people just switched to eating the same boxed and packaged foods just in a ketogenic style?
Well, there's keto junk food now, right? I mean, so how you define ketogenic, there really is no keto bread that is truly low in carbs, even though there's a company that sells keto bread, right? There's really no keto ice cream unless you make it yourself, although there's a brand keto ice cream. So no, I think the keto products that are formulated now on the shelf often don't help. And I discourage the use if someone's really trying to do a prescription strength keto type of diet. The macronutrient focus is something that I don't teach in my clinic. I teach a very simple version of a keto diet. In fact, it wasn't called keto when the diet that I teach was formulated. It was called low carb. So the reason you focus on the macros and get the carbs really low is so that your body starts burning fat. And that is instrumental and different than other dietary approaches. So low carb being the macro that it's not really a macro anymore if you're not eating carbs. So the micronutrients, very interestingly, if you're sticking to real food, animal sourced foods, there really is not a micronutrient vulnerability that we know of. I mean, I have been involved in several papers looking at the nutritional adequacy of even a carnivore type of diet where you eat no vegetables at all, no fruits, no vegetables. And it actually looks pretty solid in terms of a micronutrient source, a way of eating. So if there's the most a highly regarded nutrient of concern, well, the one that's talked about a lot is, oh, where are you going to get your vitamin C if you don't have fruits and vegetables? I'm not aware of any well-documented source of patient case study with scurvy having been on a carnivore diet. I lurk on Facebook groups and all, I'll look in from time to time. I'll look on video comments on the bottom, and yeah, I think I've seen someone who thinks that she had scurvy, that, well, it was a blood level of the vitamin C rather than the actual clinical. So if there is a vulnerability, it's not common. I mean, it would be kind of like, if you do a vegan diet, you worry about vitamin B12 and you take care of it. You take extra B12. If you're on a carnivore diet, maybe you supplement with vitamin C or some other nutrient. I don't think it's going to be a big issue, but if it is an issue, you might just supplement. I used to hear people say, well, if you have to take a supplement on the diet, it's not a great diet to follow. Well, that's basically the vegan diet. I mean, and you have to, that's, in fact, it's kind of poor form if you criticize someone for being a vegan and of course, I mean, if someone's unhealthy, regardless of whatever diet they're following, I'll as a doctor say, I think the diet is a problem here. We need to improve it. So I don't know. I think that's the reason we don't talk much about micronutrients, is that it's not an issue if you're eating animal-sourced foods.
And that's exactly how we coach, honestly, is we set the base with animal-based nutrition. Nutrients, when you're eating real whole foods, just like you were saying, you cover a vast majority, if not all of the nutrients that you need with an animal-based sources of food. And then we can bring in produce, vegetables, and certain fruits, and depending on your context, we can add additional nutrients as well from the required base, but also lots of flavor and lots of variety. And depending on who you are and how your body interacts with those foods, we can spice things up however you would like. But just set that base.
Well, I think if there is something other than the food to talk about, we usually talk about electrolytes. Just sodium, potassium, magnesium is something you might want to have extra of, just because our food has, in general, so little of it, and your body actually gets rid of the sodium better when you don't eat carbs. Which was something I wanted to mention, is that there's a issue called conditional essentiality, meaning what is necessary to eat, essential nutrient, meaning you have to eat it, you can't make it, can vary, or in the amount of the nutrient may be different depending on what you eat. So we think that on a keto carnivore type of diet, the type and amount of nutrients is different that you need to consume. I would love to see some research to nail this down, but the guidelines of what you should have per day is based on people who eat carbs, and is worried about more so that you don't have a deficiency, when what we want is an optimal level, right? Not just to avoid deficiency. So that's another issue, not just what is essential, but what is optimal can be two different amounts of that. Well, good. I'm pleased that you've come to that idea that animal source foods are important or less worrisome to consume for people.
Absolutely. And the idea that requirements will change depending on your diet is also something I find very lacking in a vast majority of research that I read. There's an inability to consider that the diet of one person being very different than the diet of another person can change the entire context about what somebody needs. And so along those lines, actually, let's get into some controversy here. Somebody comes in and to you and wants to try out a keto or even a carnivore diet, but they're scared. And so they say, I want to try this, but what about my cholesterol? What do you typically tell somebody with that concern?
Yeah, well, I get that every day. It depends on the level of geekiness or kind of like when you are asked, where do babies come from, Daddy? The response varies depending on the age of my child. So at first the stork is satisfying for an answer, and then mommy's tummy, is satisfying, but then you have to kind of eventually tell the truth. So at first I'll just say, don't worry about it. It's not an issue. And that satisfies a certain level of folks. If they, well, but you're eating more fat. And I say, yeah, because the eating more fat raises your good cholesterol. So actually, often, if the cholesterol goes up, you want to ask, which cholesterol? Is it the good one or the bad one? Now, of course, the advanced person will say, well, there really isn't a good and bad. There's a small good and a bad good. And okay, well, then we get into the small LDL, large LDL discussion. But first, I reassure people that 2/3 of the time, everything gets better across the board, even the total and LDL, the triglyceride and HDL. So, and then if someone's still skeptical, I'll say, let's measure it. Of course, you want to be careful to measure the cholesterol while someone's losing weight. It can go up regardless of the method of losing weight. And that was shown in our first randomized trial. There were people losing weight on a low-fat diet, and their cholesterol went up. Yeah, low-fat diet, the cholesterol. So when you're losing weight, I discourage the measurement of the cholesterol. So that's going to be the final, it's probably going to keep me employed till I die to talk about cholesterol and the old paradigm of total and LDL, the new paradigm of metabolic syndrome, triglyceride and HDL. But with the patient in front of me, I'll just say, everyone becomes a fat burner if you don't eat for a day or two. Every mammal does, because we store fat on our body. We store energy as fat on our body. So you start burning it if you don't eat. And this took 20 years for me to wake up one morning thinking, oh my goodness, we all go into fat burning if we don't eat for 2 days. That's the Naked and Afraid show, or it's just true. How could that have been evolutionarily possible if it was self-destruction, right? So the fear about ketosis is unfounded. It would have killed us. So when I watch someone, oh, you go into ketosis, well, everyone does that after 2 days if you don't eat for 2 days. But I've been in rooms of hundreds of people, and I'll ask, how many of you gone a day without eating? And nobody has gone a day without eating, so they think anyway. So you become a fat burner, and so ketosis is as harmful as not eating for a couple days, and people go, oh no, that's terrible, I'd be so hungry. Anyway, so you gotta be careful about that method of teaching. But there's now a researcher and a paper that changed the term, and we've used it informally, but now it's in a research paper. They say we shouldn't use the term ketosis. We should use the term euketonemia. Now, what that means is eu means normal, ketones, and emia in the blood. So it's normal to have ketones in the blood as a term. That just confuses people if you say euketonemia. But ketosis rhymes with ketoacidosis, and so people think of being hospitalized and all that. So it's kind of a minefield. I kind of like just the calm reassurance that, I've been doing this 25 years and I don't want you to worry about it. I wouldn't still have this job at a major university if I was killing people, right? And that probably doesn't reassure people either. But anyway, the cholesterol fear is out there, and the cholesterol code, the movie, which has just been released, Amazon streaming, will kind of relieve some of that fear. Don't think it will entirely, but there's even a documentary film looking at the balancing of, look at all this benefit from this diet change, and oh yeah, there was a little LDL, but these people were not concerned about it. Neither were the world's expert on the coronary angiogram. So you actually see the radiology expert look at the arteries of people, and you get to look in at those arteries of people who have extremely high elevated LDLs because of the diet. So I guess that's my long way of, don't worry about it. You'll be fine.
Yeah, that's a good starting point. I do have a few more questions if you have the time. Yeah, the cholesterol code. I actually just watched that the other evening, and it's a fantastic documentary. It should be mandatory watching for every doctor and the general population. I think it's really insightful, and even just the baseline of bringing humanity and personal decisions back into the doctor's office, and allowing individuals to have conversations with their doctors about, even if somebody is concerned about their cholesterol levels, one, maybe the concern is overblown, but maybe there is legitimate concern in certain cases. Let's work together on how should we address that concern, depending on your context, who you are. And so the cholesterol code, there follows a few stories of individuals, specifically around mental health, that the ketogenic diet has been very beneficial to improve those symptoms, which I do have a question that I want to ask along those lines. But first, I'm curious, along the lines of cholesterol now, the film covers a phenotype that has been dubbed lean mass hyperresponder. And essentially, for those that don't know that term, which is probably most people, it's almost every single metabolic marker, every marker on a blood test shows somebody is very, very healthy, except their LDL is very, very high. So they're very, very healthy, except their LDL is high. Now, this ongoing study that is I've been following for a couple years now, the early results seem to suggest that there is no relationship between the amount of quote-unquote bad cholesterol in your bloodstream and plaque depositing, which is what we're all concerned about for cardiovascular disease. So there's no relationship between LDL cholesterol levels and plaque buildup. However, there may be a relationship between, if you have existing plaque, you may be at risk for more plaque. Of course, results are very early on this, and so I'm sure the research will continue to happen. But with that data, one, I guess, maybe you disagree with how I'm analyzing that data. So you're welcome to contradict that. But if not, do you give any different suggestions between somebody that comes into your clinic that either knows they haven't had imaging, that they have significant plaque buildup, or they've had a heart attack or something, versus somebody that has no evidence whatsoever of any existence of plaque in their arteries?
Yeah, so the study that's going on that looks at people with super high LDLs on a keto diet, they also have super high HDLs. And I think that's an important point to the old way we taught this was there was good cholesterol, the HDL, and if that's really high, it's protective. Now, because there are no drugs to treat HDL, it hasn't made its way into the drug treatment guidelines, but I can raise someone's HDL by changing the food and by having them eat more saturated fat, which is kind of strange because people have been told not to have saturated fat. Well, maybe that's why their HDLs are so low. Well, so the upshot of the ongoing research and also the clinical experience of doctors, which is actually our clinical experience is way beyond the science. And so that is good and bad. I mean, that means we see things that scientists don't think are possible because there hasn't been a study published yet. So the lean mass hyperresponder phenotype, and in there, that meaning the not the genes, but the way it plays out, the high LDL, the low triglyceride, and the high HDL. Remarkably, there were people who had no atherosclerosis in their coronary arteries at all, despite 5 years of LDLs that would make my colleagues fall out of their chairs. You know, you need to be immediately, no, there's no LDL level at which you hospitalize someone. Actually, there's a triglyceride level where if your triglycerides are 1,000 or 2,000 or 10,000, we put you in the hospital and give you insulin to lower the triglycerides. So you know, calm down. You know, an LDL does not. It's not like you're on the edge of the cliff. You know, and you see someone in the film with a friend. I know her in the UK whose LDL is 600 for years, decade, and she has no calcification on her coronary arteries at all. And the doctor says, well, you don't need a drug for a disease you don't have. You know, so I think your separation of these two issues is really important. If you don't have any disease at all, and you can have these now CAT scans, coronary artery calcium scores done. It's a rapid CT scan, and that's something relatively new in the cardiology world even. In some parts of the country it's done often, in other parts you have to pay on your own to get the calcification score, CAC score it's called. If it's zero, you know, there's really, the prognosis of the next 10 years is really good, like less than 1 in 100 chance of having a heart attack. And it's even one guideline will say you don't need to be treated with a statin no matter what your LDL is if your coronary score is zero. Now, I'm not that sure that, so I will recommend that you follow up with calcification score, CAC score over time, every couple of years or even more if you have a zero level. But if you do have calcium on the calcification score, so you don't have a zero, it's a different discussion. And depending on the level of the calcification, I may say stay on the medication to lower the cholesterol level. There are studies that show that it has some benefit. Now, I point out that the benefit isn't huge, you know, and many doctors think it's the only thing they can do, so they fearmonger about medication treatment with statins or shots that lower the LDL level. You can even get the LDLs dialyzed out of your blood, and then the blood gets put back in, kind of like dialysis. But depending on the calcium score, you might even be referred for a treadmill test, a stress test of some kind, or a CT angiogram, which is looking at the arteries, and that's what is happening in that study that was portrayed in the cholesterol code. They're getting CT angiograms. So I've become a big fan, or I recommend the coronary artery calcium score because the predictor accuracy of the blood tests is actually kind of poor. So that you might have high LDLs and no disease at all. And you might have super low LDLs and you might have disease in all three arteries. So now if someone's had a heart attack or a stroke, we call that secondary prevention in the medical term. primary prevention is if you haven't had a heart attack or a stroke. So secondary prevention of heart or cardiovascular disease, just about every mainstream guideline will say that you should be on a medicine to lower the cholesterol. The nuance is it probably isn't lowering the cholesterol that's doing it. It's probably the anti-inflammatory effect of the medications. But don't tell your doctor that. That'll just confuse them. So you can see that there's, ideally you have a calcium score of 0 and you just stay away from the medical treatment, but continue the lifestyle treatment of eating, avoiding the ultra-processed typical American diet. I do have people come to me just for that discussion about their calcium score now these days because their doctors just they're not trained in it. Kind of like nutrition. They just don't know.
Yeah, I find I've had many conversations about different scans, CAC and the angiogram and such, that we now have technology that we can actually see what is happening in your arteries instead of just testing an LDL cholesterol level, which has very very little correlation with actual risk. And so these conversations that I've had with doctors oftentimes go along the lines of, my question is, in addition, at minimum, to taking your cholesterol levels, why wouldn't we at least take imaging scans now that we have the technology? And the reply that I often get is, well, depending on the test, and especially the angiogram, is at low levels of plaque, the error is really, really high. And that alone, they've already admitted, okay, so the error, yes, it becomes very fuzzy. There's lots of, we don't know exactly what's happening when plaque is so low that it's probably not something we have to be concerned about in the short term. It doesn't mean that let's just ignore. We can take imaging 5 years from now, but at the moment, plaque is so low. Why is it such a massive concern? It appears that somebody's doing something right already. So the conversations to me a lot of times, they don't quite add up. There's some logic that just seems to always be missing in these conversations, at least on my non-medically trained, I'm an engineer background.
The complicating factors are the cost, who's going to pay for it. The medical system generally won't pay for it until some study has been done that shows that if they pay for it, there's some return on the investment or improvement in health of individuals. The other is the radiation exposure. It's not 0, but the radiation exposure of the rapid CT scan for the calcium score has gone down over time, and it would be like having a mammogram. It's kind of accepted in certain populations. So Dr. Agatston, actually in the Cholesterol Code movie, calls it, we thought it would be the mammogram of the heart because everyone should get one, this rapid CT scan of the coronary arteries, the calcium score. Well, it hasn't gotten into the practice of doctors yet, partially because of the payment and the x-ray, and we just weren't trained to use it that way. But even then, I trained in a field called health services research, and you can introduce a test like a mammogram, and there's something called the burden of the false positive, meaning someone has a lump on the scan and they do a biopsy and it's normal. So there are a certain number of people who, they shouldn't have had it done anyway. And so we allow for that and say, well, we saved X number of lives from cancer, so we'll do mammograms. There are some health services researchers who have done the big system-wide view who say that it really doesn't help to do it in the big picture. Same with prostate cancer screening. And it depends which type of doctor you're talking to. The urologist is going to say, surgically, let's take it out. But there are some oncologists who even would not intervene depending on the age of someone because it doesn't progress very rapidly and all. So the ideal thing would be to have a study, large study of people with calcium score versus those who haven't had a calcium score, not just following everyone with calcium scores, that's been done, but randomize them to not have it at all and see if there's any benefit. Now, it's, whether that will happen or not, often the technology gets in place and it gets entrenched and there's never that comparator study done. But it may seem logical to have more knowledge. Knowledge is better. But just as a case, I've had people with calcium scores on the order of 2,000 have normal flow inside their artery. So when they go onto a treadmill or a stress test, they have normal flow. So the calcium is a sign of healing of the plaque in those people. And so that, it's just a tough, I wish the tests were simpler, but it's it's the physiology that's so complicated, is that even you put someone on a statin drug and the calcium score can go up, and it's reasoned that it's a sign of healing. Now, I'm not sure that's the case, but that's what they say. So anyway, you would never act on the calcium score without some other test beyond it. That's where a calcium score of 0 or 50 or something like that is just really nice to know and have. But sometimes you open this Pandora's box and the calcium score is in the 100, 200, 300 range, and doctors want to treat it. There's no study really yet that says you should treat it, but there are expert guidelines that say you should. So sorry, the engineers who come to medicine, and even Dave Feldman is a computer engineer, they just pull their hair out at how the system just doesn't, why doesn't it work like a computer? It's like, well, they're human or physiological systems usually have counterbalancing or going toward homeostasis or back and anyway, that simple feedback systems you should be able to model and all, but this calcium score is a tough test to interpret.
My takeaway as an engineer now researching health, my takeaway at this current point, or one primary takeaway, is the story around cholesterol, plaque, and heart disease is way more complicated than what it appears to be treated as in a clinical setting. And even you mentioned calcified plaque appears to maybe be a protective measure and a healing measure. For myself as an endurance athlete, I'm really curious about, it appears, endurance athletes oftentimes have more rapid progression of calcified plaque, and yet as a cohort, we have lots fewer cardiovascular disease events. So just something that I'm really curious about right now. But just briefly, I'm curious, what are your thoughts on the CIMT scan? Because to me, that seems like a really good middle ground between price, and it doesn't have the radiation that comes along with it, and it still provides very reasonable information.
Yeah, so the CIMT for the carotid intimomedial thickness, CIMT, is an excellent test. I mean, it will look at the thickness of the carotid artery, so CIMT for carotid. And the problem is it's relatively difficult to do compared to just a Doppler ultrasound. So there are companies that go around doing the ultrasound technique, and I think it's reasonable to do the carotid and the aorta with these companies to get your own information. The CIMT is better and more sensitive. It's just less available. And again, that's that availability thing. And then, do you want the system to pay for it? Not yet. So you have to pay out of pocket for these tests, I'm afraid. All of these tests have what's called operator dependency, meaning who does the test can influence how good the test is. It's not like just taking a photo. So you have to find the artery and do it, and most people are trained well. Some are trained well and they're not awake that day or something. I don't know. So you always want to be sure that it's done by a reputable group. But I like the CIMT. I just don't order it much because it's not available in my area.
Mm-hmm. Yeah, still good to know the pitfalls around any individual test that you might get. Circling back around to the cholesterol code documentary and focusing on, it's all about the ketogenic diet and the benefits for mental health. And most people are shocked to even consider the fact that in this documentary, it follows a handful of people that have very severe clinical mental health disorders, schizophrenia, bipolar disorder.
Yeah.
One thing that I am really shocked about, we talked about, despite most or many doctors not really knowing what to do on the nutrition front, most doctors would agree that yes, nutrition impacts your weight, impacts certain things about your health. And we even have the phrase, you are what you eat. But I find that there's been an even more heated discussion around the idea that a ketogenic diet, there's no way that a ketogenic diet can have any impact on a mental health disorder. To me, it's the most natural thing in the world that what we're putting in our mouths is fueling not just our body, but our brains. Our brains also need energy. Our brains need nutrients. So why do you think that there's an extra intense pushback against even the concept that there's a chance that nutrition could impact the way that our brains function?
Well, yeah, I don't know all of the barriers to, doctors actually are, if you do a rotation in pediatrics that has a pediatric program for childhood epilepsy called the ketogenic diet for childhood epilepsy, you learn that changing to a keto diet can actually reverse seizures. That this is a brain disorder. It's called a seizure. So the fact that diet can affect the brain is kind of obvious if you've had that. Oh, but is a seizure related to mental health? That's psychiatry. So we've artificially put neurology and seizures over here and psychiatry and mental health over here and internal medicine and diabetes down here. And it's all part of metabolism, and nutrition does matter. My first case study that I wrote on schizophrenia reversal on a keto diet was published many, many years ago. And then I knew that patient for the next 10 years, and she had no recurrence of voices and visual hallucinations, and she passed away during COVID. But the other case studies were seen about bipolar and schizophrenia reversal, and then Matt Bazuki's experience in the cholesterol code of bipolar getting substantially better. He gave a talk at the COSI conference, and I think he's on one medicine still, but he was on 5 medicines and it didn't really work. So a diet change can potentially have big effects, above the neck for seizures and mental health problems. But it goes back to the Bible, that fasting or starving was used for people with fits, meaning seizures, and the idea that this might help with obsessions and all has been around a while. For in the 1970s there was a paper, but it's very sketchy, that it's hard to know what they really did. But the psychiatric world for bipolar and schizophrenia became enamored in using drug therapy instead of dietary therapy, and there were no ways to teach keto diets with real food. So I think what's happened now is that there's an awareness of keto for diabetes and other metabolic issues, and now the idea that this might help and be available for severe mental illness is coming to a meeting, in time now, which now, because there are some case studies, doesn't mean it's going to help everyone. So you have to be cautious with, and this happens with diseases like cancer and rare things, even like MS or ulcerative colitis. There certainly are people who can reverse those, but it doesn't mean it will work for everyone. So, time out. Let's collect some prospective data. Enroll 50 people with bipolar in a study, and teach them and make sure they understand how to do it. They can measure ketones, perhaps. Fortunately, that study or that science is going on now, and that was because of the philanthropy of the Bazuki Group, the owner of the Roblox, a popular app. His son Matt was the one who found the diet and got so much better. So hopefully there'll be more science wrapped around mental health and just general metabolic health. The Bazuki Group has already started a group called the Coalition for Metabolic Health, which is not just the brain health. And I'm afraid we're stuck with this artificial dichotomy of neurology, psychiatry, I guess ENT and dentistry above the neck, and then internal medicine, below. So, yes, the whole body can improve with metabolic health improvement, and I mean that was the gist of Chris Palmer's book called Brain Energy, is that the metabolism is wrong in people with schizophrenia and mental health. And by fixing the mitochondrial health and metabolism, you can actually fix mental health disorders. It's a brilliant book. Georgia Ede also wrote a book, Change Your Diet, Change Your Mind. Those are great introductions to the idea that changing your food can help mental health problems.
Yeah, Georgia Ede's book is one of my first suggestions for anybody that wants to start to dive in a little deeper into metabolic health. And actually, Chris Palmer's book is one that's on my bedside table right now that I'm actively reading. But yeah, absolutely, the Bazuki family, it's very incredible what they are doing, and hopefully their funding is going to start a broader trend researching this. Along the lines of research, I'm curious, again, you've been doing this metabolic health in your clinical practice for well over 2 decades. You have a ton of experience. So with that, is there any specific research that you would like to see done? One, something that you have discovered in your practice that you would like to see published in a journal that can then be used to convince other practitioners, so to be true, that you would like to see the research evidence of. But then 2, is there anything that you are unsure about when it comes to a ketogenic style diet that you would like to research or have that research be done because you don't know and you're curious about?
Well, yeah, the list of all the things would be another conversation. The talk I gave at the Las Vegas fundraiser for the Citizen Science Foundation, I hope will be online, and it was a kind of survey of what research has been done on the keto diet up till now in broad terms, and then kind of a manifesto or where should we go from here, which but the easier question is, I'd love to have a researcher, and I'm close to getting someone who might do it, go through our files, our computerized data, to do a retrospective review of people that we've seen, from at Duke, it takes time. I've had a student and a young professor uh, put together retrospective reviews that were specific to heart failure and to kidney disease, which were interests of theirs. But there's a lot of data on type 2 diabetes, obesity, other issues that are more uncommon, but still interesting, so that would be fun to do a retrospective review. For prospective research, there's a saying that we can, in the clinic, work hard, we go home, we help people, and we feel satisfied. But if we went upstream and stopped people from jumping in the river, that then they end up in our clinic, meaning they stop eating carbs or to get metabolically healthy when they're younger, before they're here at the clinic, you're going to help many, many more people. So I'd love to see the research, not just therapy for diabetes and all that's what I do in my clinic, but it needs to go upstream and start studying kids, start studying pregnant women and pregnancies, start studying families when they're school age, so that we're seeing diabetes and fatty liver and cirrhosis of the liver in children. So I'm an internist, and in fact at this meeting I said, where are the pediatricians? I mean, we need to have them involved actively in the research of using keto in their populations. But even then, it's a public health issue, and but it's complicated, as you say. It has to do with the food, the biases we bring as to what is good food, and but the idea of changing what a family eats, maybe even funding a family's food for a month, seeing what can happen, teaching them what to do. I mean, so in my area, people aren't taught much about how to prepare food. Not that, and then the doctors are over here with culinary medicine making high-end cuisine. I know we need to have it to be very simple sorts of ways of going about it. It shocks people when I tell them the story of the man I treated who lost 100 pounds eating at McDonald's, thinking, oh my God, fast food, you can't have fast food. No, if you teach them to not eat the carbs at McDonald's, they can actually lose 100 pounds. So, it's an exciting time because there's an awareness. There's even a national guideline that points in this direction, and maybe even there's money. The philanthropy has a long story in the low-carb keto world, and it started with the seizure issue. It was a son of a movie producer, and Charlie was the son, and the Charlie Foundation has taught how to use a keto diet for childhood epilepsy for the last 30 years, and yet it's still not in the neurology office because they're using drugs. So I don't think we'll ever get away from drugs, and it might even be for a while stay away from the clinics, and let's go upstream and start doing research on how we can teach the younger folks, teach families, teach schools on how to have real food, and then that impact will be spread. If you wait until people are in the office, I mean, yeah, I'd love to do a study with type 2 diabetes. I'm trying to, but that we can help many more people if we are doing what you do with people way before they end up in the clinic.
I absolutely love that response, and I agree. My wife and I, we are coaches together. We research and coach together. She's much more on the food and actually how can you make simple meals that take 5 minutes that are truly nutritious. But ultimately, we have wanted to work a lot more with families. We want to make an impact in kids' lives so that they never get in the position that, sorry to hopefully work you out of a job, Eric, but we want to allow
Okay.
people to never be in that position. But unfortunately, to this point, we've really only worked with people in the retired age bracket, and then myself with some athletes. Because athletes know nutrition is important, and people in the retired age bracket, they've hit rock bottom. They're saying, I don't want to take 12 medications. I need to do something different. Finally, I'll turn to nutrition. And young families haven't hit that proverbial rock bottom yet, and so they don't have that motivation. We both need the research, especially the research of, how does a ketogenic diet affect the growth for children? How does it affect their growth patterns and all that? And we need more research in that field, but we also need the awareness and the culture for people to find it normal to turn to nutrition for health. So much of what you said, I could have pulled on so many threads, and I could be asking you questions for days, but you've already been very, very generous with your time. So
let's
I will
talk
let you
again
go,
sometime.
but would love to. Before you go, let people know if they, if you were taking clients, if somebody's interested, or patients, if somebody's interested in more clinical assistance from you in your clinic, or if somebody just wants to learn more about you and listen to what you have to say, where can they find you?
Yeah, the easiest information to get that I put out is at my YouTube channel, Dr. Eric Westman, or it's also called Adapt Your Life YouTube channel. I have a company that teaches online called Adapt Your Life Academy. I have a couple books out there. The latest one is the best one, End Your Carb Confusion. And then if you really do need a doctor to help you, I am at Duke University. There may be a waiting list, but you can call 919-471-8344 and ask for an appointment with Dr. Westman. I don't do telemedicine. I don't do medicine at a distance. I'm licensed in North Carolina.
All right, well, that's good to know. But I will add all of that information in the show notes. So thank you so much for joining today.
Well, my pleasure, and keep up the good work.
Thanks for tuning in. We're here to help you put what you've learned into action. Learn more about our coaching program at highenergylife.com. That's HIenergylife.com. Until next time, embrace nuance, ask questions, and always reserve the right to change your mind.